secondary amenorrhea. So how do you classify? Classification according to the cause. The physiological cause, pregnancy, lactation, menopause, and hormonal pills also can cause amenorrhea. And in the hypothalamus, stress, weight loss, eating disorders, excessive exercise. In the pituitary, hyperprolactinemia is one of the common cause. Sheehan syndrome and pituitary tumors. There are quite a few Sheehan syndrome patients coming back now for a different reason and then found to have a hypopituitarism, started on treatment. They have Sheehan's at the time of delivery and then they come back after 10 years with secondary amenorrhea. They come for a different reason. And ovarian, PCOS, which is most common problem, and primary ovarian insufficiency. Thyroid disorders, hypothyroidism and hyperthyroidism. In adrenal, Cushing's, congenital adrenal hyperplasia, and androgen secreting tumor. This is general prevalence. PCOS in adolescents cause higher secondary amenorrhea. And then next, primary ovarian insufficiency and functional hypothalamic amenorrhea. So other causes, hyperprolactinemia as a pituitary cause, and also the gynecological cause like Asherman syndrome also included in it. So how do we approach? First, history itself can tell us the diagnosis in many patients. So first, to identify whether any eating disorders or emotional stress or excess physical activity, chronic illness. If it is a hyperprolactinemia with a pituitary, you will get visual symptom disturbances, headache, and symptoms of hyperandrogenism, symptoms of hyperthyroidism. Menstrual history is more important, and past medical history. And last but not least, sexual history. We don't want to miss the pregnancy. How do we examine the patient? So generally the metabolic risk factor, including the height, weight, and body mass index, and the neck examination gives us a clue about the thyroid swelling and looking at the features of PCOS, then pelvic examination to rule out the outflow obstruction cause. So as soon as the patient comes in, we do a pregnancy test. If it is positive, we look into pregnancy and related diagnosis. In pregnancy and lactation, HPO axis suppression happens, and which leads to hypogonadism. In menopause, natural ovarian failure. Once we ruled out the physiological cause, next we do a set of blood tests like TSH, free T4, prolactin, LH, FSH, and estradiol. So imagining all the other tests normal except FH, how do we go about next? So FSH levels, if it is high, hypergonadotrophic, along with low estrogen, hypergonadotrophic hypogonadism, which is a primary ovarian insufficiency. If both low, it's a hypogonadotrophic hypogonadism. If it is normal, it's going to be eugonadotrophic, which is a PCOS and outflow tract obstruction. So when FSH is high, below the age of 40, with symptoms of menopause, like vasomotor symptoms, dryness, mood changes, any previous history of chemotherapy, radiotherapy, vulvovaginal atrophy, with the rest of the bloods normal, we have to think about primary ovarian insufficiency. Usually we do 2 bloods with 4 to 6 weeks apart. The prevalence is less than 1% in less than 40 age, 0.01% in less than 30, and 0.01% in less than 25. Early menopause is between 40 to 45 years, which affects 5% of the women population. Natural menopause, the average age is 51 years. What happens in primary ovarian insufficiency? Instead of the maturation of the follicle, there will be early follicular depletion, blockage of follicular maturation, destruction of the oocyte pool. So the causes could be iatrogenic, as from the history I've explained, could be radiotherapy, surgery, or it could be genetic. And also we have to think about the autoimmune causes, which are more common nowadays, and sometimes it could be due to infection, metabolic, and idiopathic is the most commonest cause of primary ovarian insufficiency. Once we get the diagnosis, how do we do? If it is iatrogenic primary ovarian insufficiency, we deal with the underlying problem. If it is non-iatrogenic, we have to think about the differentials, autoimmunity, genetic, and rest of the rare causes. So if the woman is less than 30, I would suggest karyotype testing. If abnormal, we have to think about Turner mosaic, and refer to appropriate specialty if required. And if it is a Y chromosome, it's a Swyer syndrome with female phenotype and streak gonads, which needs gonadectomy. If it is a normal and if suspicious of Fragile X syndrome, then testing for Fragile X. And if it is negative, in our mind, it should run about autoimmune screening, thinking about thyroid, adrenal, type 1, all those problems, and screened appropriately. If it is positive, if it is none, then we have to think about idiopathic. So we know the patient has primary ovarian insufficiency. How to approach the patient? So basically assess the risk factor of cardiovascular disease, assess the risk factor of bone health, calcium, vitamin D, and DEXA scan. Then think about the hormones. Is the patient going to need a fertility or menopausal hormone therapy? If it is fertility, to the appropriate specialist. If it is menopausal hormone therapy, then we have to rule out the contraindications like estrogen-dependent cancers or significant thromboembolism. If there is a contraindication, we'll think about the non-hormonal treatment like SSRIs and gabapentin, clonidine. If there is no contraindication, if the patient has uterus, if the patient doesn't have uterus, then it's estrogen-only MHT, menopausal hormone therapy. If patient has uterus and contraception is required, it's going to be combined oral contraceptive pills or the levonorgestrel intrauterine patch to prevent pregnancy. And then if there is no need for contraception, it's going to be either cyclical combined menopausal hormone therapy or continuous combined menopausal hormone therapy. Lifestyle is more important, and psychological counseling due to the hypogonadism, due to the diagnosis, due to mood disorders, we have to refer to the appropriate psychologist and mental health team. There are also other treatment we can consider like cognitive behavioral therapy, mindfulness, yoga, physical activity, etc. So what is the pregnancy planning in the primary ovarian insufficiency? Approximately 5% of the women can conceive. Among them, 25% of primary ovarian patient can ovulate, only 5 to 10% can conceive. It's extremely scarce. So there are options like oocyte donation in the treatment of fertility, and proven success rate is around 70 to 80%. Immature egg cell donation in the Turner syndrome, but we have to make sure the cardiovascular status is okay, so IVF conception, and also egg freezing, and other uncommon like ovarian tissue cryoprecipitation, embryos are also available. In a patient with a malignancy who is undergoing radiotherapy, it is possible that we can protect the ovaries by moving out of the uterus more on the higher side to protect the ovaries for further fertility plans. So the next we finished about the high FSH. Now the FSH, normal or low normal. So we have to go in the path about the history. So if it is a weight loss, disorder eating, high performance exercise, chronic illness, excess psychological stress with a low BMI, and vulvovaginal atrophy and breast atrophy with the other blood test normal, we have to think about functional hypothalamic amenorrhea. On the other way around, if there is a weight gain with high BMI and futures of hyperandrogenism, we have to consider polycystic ovarian syndrome. And also hypothyroidism, if there are any symptoms of hypothyroidism, we have to think about it. And because it's endocrine, I'm just leaving the Asherman syndrome and related problem for now. So what happens in functional hypothalamic amenorrhea? Due to all the reasons that I have explained, stress, excessive exercise, disorder eating, there is excess cortisol secretion and also decreased leptin secretion, which lowers the HPA axis, which results in hypogonadism, which can cause cognitive impairment, depression, euthyroid, that is non-thyroidal illness, increased cardiovascular disease, amenorrhea, infertility, and low bone mass. How do we treat the functional hypothalamic amenorrhea? First, lifestyle and nutrition is more important, increasing the energy availability, calorie intake, reduce the excessive exercise, gradual weight gain is needed, and increasing the body fat restoration. They need psychological input and cognitive behavioral therapy for them to improve. So after 6 to 12 months of the above treatment, if still they doesn't have periods, then we can think about hormonal treatment. So we come back about the hormonal treatment and fertility a bit later. If the FSH is low normal, then we have to think about pituitary causes. The pituitary causes are prolactinoma, Sheehan's syndrome, and pituitary tumors. There are quite a lot of causes that have listed on the right side. So hyperprolactinemia, we are going to discuss in the galactorrhea session also. Elevated prolactin suppresses the hypothalamic gonadotrophin releasing hormone secretion, and which lowers the FSH and LH, which results in anovulation and amenorrhea. The other causes of high prolactin are medication, because as soon as the patient with hyperprolactinemia comes in, we have to look at the medications that involves antipsychotics, antidepressants, antiemetics, prokinetics, estrogen, verapamil. Sometimes we also do a TSH because hypothyroidism causes the negative feedback and increases the secretion of thyrotrophin releasing hormone, which increases the secretion of prolactin. Or any chest wall trauma stimulation can also increases the prolactin. So the symptoms wise, galactorrhea, headaches, infertility, visual disturbances. And going back to other pituitary causes, macroadenoma, presses on the stalk, which also can lead to hyperprolactinemia and also panhypopituitarism. So when we think about the pituitary cause, we have to look into the associated hormone deficiencies like cortisol, hypothyroidism. Once we know that hyperprolactinemia possibly due to medication, we need to consider holding the medication and retest. If it is persistent hyperprolactin, then we have to do a pituitary MRI. The treatment in detail we can be discussed later, and usually carbapenem that we give nowadays. And we have to follow up with after giving the carbapenem and to see prolactin is going down. So Sheehan's syndrome. Sheehan's syndrome, like I previously said, during pregnancy, the lactotrough increases the pituitary hyperplasia with a limited vascular supply. When there is a postpartum hemorrhage due to hypotension, the ischemia of the pituitary can happen, which cause hypopituitarism. So the entire pituitary profile needs to look into and replaced accordingly. Polycystic ovarian syndrome is eugonadotrophic hypogonadism where FSH is normal. So diagnosis according to the Rotterdam criteria. So with history and biochemistry, sometimes we may not need ultrasound. 17 OHP we have to do, which is often missed if any clinical suspicion of non-classical CAH. And if it is a marked androgen excess, we have to evaluate for tumor of the adrenal gland. So how do we treat PCOS? Usually, the first line is lifestyle. Weight loss is encouraged to improve hormonal balance and ovulation. If insulin resistance, metformin should be considered. And nutritional counseling is more important. And to protect, if they cannot stay longer without periods, to give progesterone. And if there is androgenic symptoms, we have to consider contraceptive pills. And in thyroid and adrenal disorders, like androgen secreting. So we discussed about so many other causes. These are all rare, which we need to keep in mind and diagnose accordingly based on the symptoms. So clinical rationale for hormonal treatment, whom do we give? If it is less than 45 and central estrogen deficiency, we give hormonal treatment. Why do we give? To prevent symptoms and to look into associated, improve the bone health, and improve the cardiometabolic outcomes, and improve the quality of life, and potentially reduce the mortality. The common estrogen plus progesterone. If uterus is present, we add progesterone, and no uterus, estrogen is acceptable. Evaluating the breast and thrombus. So this one we already discussed. levonorgestrel IUD also can be given, which avoids it lowers the systemic exposure and is a convenient contraception. The duration of treatment in young women provide physiological replacement dosing through the average age of natural menopause up to 50 to 51 years, unless there is no contraindication, continuing longer if symptomatic after shared decision making. We can give either sequential therapy, where daily estrogen and progesterone for 10 to 14 days. If it is a combined, we can give daily progesterone, where amenorrhea after an adjustment phase. Regimen forms 17 beta estradiol is preferred compared to other estrogens because of the physiological replacement. It also able to allow measuring the levels during fertility treatment, and the dose is usually 1 to 2 milligram per day. If you are giving conjugated equinestrogen, which is the dose is around 0.625 to 1.25. Transdermal patch is available, but we are not using due to the tropical climate and the availability. There are gel and vaginal rings are available. So why do we think about transdermal? It bypasses the first pass metabolism and reduces the risk of VTE. In hypopituitarism, when there is a growth hormone therapy also given, switching from oral estrogen to IGF actually lowers the growth hormone dosage, because the oral contraception increases the level of IGF-1. Progesterone option is micronized progesterone, which is a natural progesterone, 100 to 200 milligram. Medroxyprogesterone also given. Fertility goals, we have several options like gonadotropin, GnRH antagonist, pulsatile. Commonly used is gonadotropins. In hypothalamic amenorrhea, pulsatile GnRH also used because the pituitary is intact. So I have put it in the slide. Due to time, we'll just move on. So this is a flow chart, nicely describes how to manage, how to approach it. In this, sometimes what we do when a patient comes in with secondary amenorrhea, we give a progesterone challenge. If it is positive, like if they are having periods, it's due to chronic anovulation. If there is no periods, we look into the higher cause with both estrogen and progesterone deficiency. Despite that, if there is no bleeding, most likely the cause is Asherman syndrome, the local uterine problem. In summary, progesterone challenge test assess the estrogen status and outflow tract of obstruction. So red flag indicators galacturia, check. Prolactin, virilization, consider androgen secreting tumors. Hot flushes, consider karyotyping and fragile X investigations. And bone protection and cardiovascular risk assessment is more important in secondary amenorrhea. Decide and discuss with the patient about the fertility and menopausal hormone therapy. So if fertility is considered in hypothalamic amenorrhea, pulsatile GnRH can be considered. Thank you.